Bismillah, walhamdulillah, wassalatu wassalam ala rasulillah. Thank you very much. So I'm meant to be talking about health in all policies, and I will cover some reflections, maybe on some of the experiences that Prof. Alam has already mentioned. But I want to talk about planning in health, and thank you to Mayada for giving us such a comprehensive framework for how we should plan for health. But would also like to talk about health in planning, and just explain what I mean about health in planning other people's business, and that's where the influence comes in. And then end with some recommendations for the wider health system. So my learning journey, and I'm still learning. So I am fully qualified, and I did specialize in the Sudan. And from that, I've learned quite a lot. I worked in the UK for 12 years, and I took back some of that learning for another 3 years in Sudan, and I learned quite a lot in the Sudan as well. And now I've been spending my last 3 years in Warrington, where again, as you can guess, I've learned a lot as well. So you can see that I've got such a strong belief in learning and continuous improvement. And that translates to organizations and translates to health systems, where we can value people and we can develop learning organizations. And as a whole system, we should invest in people. So I want to reflect really on what's good about Sudan and some of the really successful initiatives, and shine light on the Public Health Institute in Sudan, where I worked as the Deputy Director for 3 years in 2010 to 2013. Now in Sudan, where you have a Public Health Institute that's set up by the Federal Ministry of Health, that says something. And the Public Health Institute is meant to focus on education and training, production of human resources for health, health workers, not just doctors, not just medical assistants, but a whole range of health professionals. We conducted research, and some of the research I will present some glimpses of today, and also some consultancy to the health system, where we developed a strategic plan for cancer, strategic plan for epidemiology, and international health regulations. And so really, the الصحة, the Public Health Institute, is somewhere where I learned a lot about how health systems work in Africa. And like I've said, I've learned a lot about making a difference. I think on reflection, I've learned as much from Sudan as I've tried to put back in there. So what I took back from my 12 years in the UK, I took back evidence-based decision-making, I took back strategic planning and research and evidence into practice. But I also learned about health systems, mobile health, health diplomacy, human resources for health planning, and I also learned a little bit about economics. So I came back into Warrington, and I think one of the big messages from the Sudan is how can the economy play such a big role in people's health and well-being? And I knew there was something about the economy that I didn't quite get as a health professional. And so I came back with messages that strong resilience, that you can withstand economic pressure. In Sudan, prices increased fourfold, and communities carried on, people carried on caring for each other. Now that's a message that you take back here into the UK, where we know we have pressures. And we are talking about community resilience here in the UK now. In Africa, it works. And then I've also sort of come back with a little bit broader knowledge about policy and politics. And public health moved out of the NHS into local authority, where very much it is a political organization. And I still insist that economic problems have economic solutions, and that resilience and optimism take you a long way. And I applaud Mayada's framework, because it really is about being resilient, being optimistic, and moving forward. And I've also learned that when you have plan A, you have plan B. I mean, you'd be surprised, we've got a plan Z actually, because you have to plan alternatives and contingencies, just in case what you thought might happen doesn't happen. You have to deal with something different. So how does change happen? Change sometimes happens accidentally. And quite a lot of the sort of changes that we've seen in the Sudan have happened due to policy changes. I hesitate to say politics, but policy changes over a number of years. And those policy changes have affected us all. So there's an urgency here in the UK, and there's an urgency there in the Sudan. But here in the UK, we're talking about harnessing the pound. So in Warrington, we talk about the Warrington pound. How can we make sure that the whole Warrington pound that's invested in education, in health, how can we invest that pound into people's health and well-being? And in the UK, we say, be the change. So there's a lot of emphasis on volunteering. In Sudan, there's a different kind of urgency. We have decimated the professions in the Sudan. all kinds of professionals, education, health, all professionals. We've decimated the value of the pound. And what, unfortunately, we've seen happen accidentally is that we've decimated quality. And when you lose quality, it means you can't depend on the pen to write, or the tap to open to pour the water, or the door to open. And that's what I mean by decimating quality. And I just remind ourselves, until they change themselves, and that's the slogan that we have already in the Sudan, حتى يغيروا ما بأنفسهم. And I think that's the key message that we have to take back. And so for both these challenges, wherever you are, Canada, America, UK, Sudan, Zimbabwe, you have to be the change, you have to change yourself, and it's the same solution. It is about system leadership. It is a journey of exploration, and we have to find the win-wins. And I suppose in my next few slides, I'm going to give you some examples of win-wins that are already happening in Sudan, just to raise the level of optimism and resilience that we already have. So I'll talk about planning and health in the Sudan. And this is something I learned, the WHO building blocks for health system development. And they focus on, you have to have leadership and governance in the healthcare system. You have to have enough funding, which is healthcare financing. You have to have the people to help deliver quality healthcare, and that's the health workforce. And of course, you have to have the medical products and the technologies and the medicines that go with that. And if you want to develop your services, you also have to invest in information and research. And so these are the system building blocks that the WHO proposes. And ultimately, the goals that we want to achieve are we would like to improve health, we'd like to improve equity, we'd like to improve efficiency. So we really want to improve quality and safety in the healthcare system. And these aren't just the WHO health system building blocks, they're also the framework for the local strategic plan for health in the Sudan. And this is the National Health Sector Strategic Plan, which again, focusing in terms of inputs on the 6 building blocks that the WHO has put in. And it's a very aspirational program that looks towards universal health coverage through primary health care, access to services that are affordable, including for poor people, through health insurance, better quality of service delivery. And ultimately, the impact that we would like to achieve are improvements on what were the Millennium Development Goals. But also flagged within that logical system planning framework, there's the influence of the other sectors that affect health. There are other determinants acknowledged there, clean water, education, and all of these other sectors that have such a focus on, such an impact on health and well-being. And actually, that's the lightning. And this could either be the light bulb that wakes up and rejuvenates health in the Sudan, or it could be the ultimate tool of destruction if we don't pay attention to these wider determinants. The National Health Sector Strategic Plan, the goal is to improve health and to reduce inequalities. But when we go fast forward from the baseline in 2011 to the target by last year, 2016, we discover that we will not have met, and actually we did not meet, our Millennium Development Goals for infant mortality, maternal mortality. And at the moment, how many of our deliveries are attended by skilled birth attendants in each state of the Sudan? So there are big question marks. What that says is that while these actions have been necessary, they have not been sufficient. So what are the solutions when we know that 14% of the population do not have a health facility within 5 kilometers? Whereas at the moment, we know Sudan's mobile phone penetration is increasing. So everybody has access to a phone, but not everybody has access to a healthcare facility. And of those health facilities, only 31% provide the full service package. This data is 3 years old, so I know that the health insurance and Ministry of Health and global partners have been investing further in this. But still, we know that we haven't achieved full service packages in all of our primary healthcare facilities. So the problem is we have fragmented services, we have weak referral systems, and that's a historic problem that we know we've always had. So going forward, with this in mind, where we are now, we know that any solution for one setting, there are already barriers to transfer into any other setting. You can forecast different options. You can set up an outreach service. Maybe we could use mobile phone technology to deliver essential health care to the people. This is a conceptual framework for delivering universal health care through family health services in the Sudan. And again, it is based on the 6 building blocks. And again, so the common theme is that planning in health is based on healthcare building blocks and does not effectively consider the wider determinants. And if we were to calculate, EMRO estimates that for 2020, for us to achieve universal health coverage, we need in excess of 13,500 family physicians or family health practitioners. And that volume, I mean, we can produce, but we also export. So there are challenges to universal coverage. And the challenges that I highlight are about inflation, about the wider system issues, about subsidies for the poorest, about availability of health services in rural areas, and of course, migration of health professionals. We know in 2011, 2012, that we had inequitable distribution of health providers and health outcomes. So if we were to look at this graph of maternal mortality against the number of health providers in each state, we see that the states with the highest maternal mortality have the lowest numbers of human health resources. And Khartoum, which is one of the best, has the largest number of health providers, of course, because it is the capital, but still, there are some others who have even lower maternal mortality than in Sudan, than in Khartoum. And of course, that might be about the sicker patients trying to come into the system in Khartoum to get more desperate treatment measures. And we did some research in 2013 in the Public Health Institute. At the time that we were looking at developing human resources for health in 2013, that was the time of the biggest wave of migration ever. At that point, 86% of health professionals were intending to migrate, linked to better economy overseas, better living and working conditions, and better postgraduate study opportunities. When we were projecting over the next 10, 15 years, we put in a scenario of attrition that we said we would lose maybe 15% of the health workers that we train. However, this is unrealistic because even if we were to train more, we know that we don't have enough posts, enough jobs, and the challenge of migration. But we concluded that there are some people who stay. And we know that we have some colleagues who are working in desperate conditions in the Sudan, really trying to make a difference. So for them, we recognize that there needs to be a minimum level of financial remuneration, even though it can't compete with migration, but at least it improves standard of living for our health professionals working over there. We also recognize that education and production of healthcare workers is really important, and that we will maintain the skill imbalance of overproduction of doctors compared to other health professionals because the numbers of medical schools far exceed the numbers of other nursing and other allied health professions. So both these, economy and education, highlight the effects of the other sectors on health and healthcare delivery. But okay, so what are the opportunities in that? So if we were to look at the opportunities of health in economic planning, health in education planning, health in telecommunications, then maybe we could also get some additional dividend. Here in the UK from 1999, of course, it was that very clearly decision makers have to recognize the impacts of their decisions on health and on health inequalities. So if you are designing a town, if you are designing a building, if you are designing a new service, if you are delivering an existing service, you have to consider the impact of your activities on health. But we know that at the same time, the development in Sudan has seen an economy boom, and we've also seen an economy bust. But at the time of the boom, we weren't really thinking of the impact of that boom on health. And what we've seen as an accidental change is an increase in health inequalities because the boom happened to the areas of most affluence and most ability. But there are some shining examples. So with the Public Health Institute, we were asked by Khartoum Refinery Company to conduct a health impact assessment of their activities. Now that is a photograph of the refinery just on the outskirts of Khartoum North. And its vision is to provide green energy and serve the Sudanese community at a time of economic boom when petroleum was really one of the lifelines of the country. Now, we did conduct a health impact assessment, and we found the best industry standards ever being applied in that facility. And we found, however, that In the vicinity, there was Garri Free Zone, there was Garri Power Station, there was Ras Al Khaimah ceramic industry, and the impacts of these industries on the surrounding communities, of course, we couldn't assess. The main point is that health impact assessment is not new. Best industry standards are not new, but by adopting best industry standards in our industries, we can influence better health for the communities living around these facilities. And this brings me to quality as a core business. Quality is part of the business. If you're producing taps, if you're running a health center, a focus on quality means that ultimately you deliver the best possible service and the best possible outcome. Actually, you become dependable and accountable. And this is just a short poem that says, "For the want of a nail, a battle in the kingdom is lost, and all for the want of a horseshoe nail." This strikes home really that if we think that what we do is too small to make a difference, then the battle's already lost. So I want to talk about the added value of business in the private sector. We talk about the growth of the private sector in the Sudan, and particularly we also talk about the growth of the private medical sector in the Sudan. Now, this is just an example from Warrington, where we are trying to harness the Warrington pound for the health of Warrington people. We could use the same model to harness the Sudan pound for the health of the Sudanese people. And the goal is to just bring in the benefits of economic growth into health and well-being. And we can do that by looking at environmental sustainability. And many of the reputable businesses already look at their environmental sustainability, how they handle waste, how they travel, how they bring their goods and products, and how they deliver them. A focus on providing healthy products and healthy services. So, for example, if you're a food outlet, then again, making sure the quality of food delivery. Harnessing CSR, and CSR is not new, corporate social responsibility. All our big industries have a corporate social responsibility, but how is that spent and where is that spent? And a focus on local jobs and supply chains. So, for example, where the example was given of the Grameen Bank, that was really focusing on the local villages, the local jobs, local supply chains, and really working to improve their economy and to improve their power of the collective. And I give an example of mobile health technology as one of we can invest in more use of mobile health technology, for example, in expanding the coverage of national health insurance. And this was a research work that we've undertaken with the National Health Insurance Fund. And we looked at how we could use mobile money as a way of mechanism for people who aren't employed in the public sector to pay their health insurance premiums. Or we could use mobile money to pay health workers working in remote areas. So we could use our good mobile network and work with the telecommunications industry in partnership to deliver mobile health promotion messages. We could deliver mobile money solutions as well. And lastly, I will end with some recommendations for the wider health system. And the general direction is that we shouldn't just focus on the 6 system building blocks. We should also focus on global influence, national policy, and local systems. And that actually, if we are delivering a service for communities, families, and individuals, we should involve them within our planning. An example of good practice. The Global Health Strategy for Sudan in 2013 was developed not just by the Ministry of Health, but in collaboration with the Ministry of Foreign Affairs around health diplomacy, with the Ministry of Trade around trade and health, and with the Ministry of Social Affairs around the shared challenge of social inequalities and not meeting the Millennium Development Goals. And translating that national planning to a more local area, I think what we need to consider is what our colleagues in Sudan keep reminding me is wilayat wizarة الصحة على الصحة. And that is actually that leadership and provenance of health should be the responsibility of the health sector, but they should influence all of the other sectors as well. And there is an opportunity of a National Coordination Council for Health that currently exists to coordinate the health sector contributions, to broaden that into all the umbrella policies for the country should go through this council for their potential impact on health. So through that council, conducting health impact assessment of education policy, of trade policy, finance, developments, any new large investments or any new large donations that come into the country, we could maximize the health and well-being benefits of that. And the other thing to say is that we should let go of, this is my resource as a State Ministry of Health or as the Ministry of Education, and move towards our common interests. And within that, it's not just the public sector, but it's also the private sector, the academics and universities, and having a more prominent voice of localities and communities. حتى يغيروا ما بأنفسهم. Oneness in 2002 said that with a disengaged public, you can spend more than half what you currently spend now on healthcare, and it would not be enough. But if you were to fully engage the public, then the use of resources would be more efficient. Life expectancy would go beyond what we currently plan for. And so it's not just about informing or consulting, neither of which we do well. Informing happens in the media, newspaper propaganda and headlines. Consulting does not happen enough outside each of individual sectors. We should involve, we should collaborate, and we should empower the currently disempowered. This comes to the end. I think we are nearly there. This is a cartoon from my colleague Monem. I love using it because it shows us really at the bottom of a very steep hill that we can only climb up together if we all collectively move towards an organized effort of collaboration. جزاكم الله خير.
دكتور بس if you can clarify that point ولاية وزارة الصحة لو على الصحة الحاصل شنو بيسوي؟ so البوينت ديت هي what can you clarify the point ولاية وزارة يعني who is controlling الصحة في السودان now?
I think it is as fragmented as we feel here in the UK, where we have federal ministries of health, we have state ministries of health, we have National Health Insurance Fund, we have Ministry of Social Affairs, and also we have police, different health service, we have army, different health service. And so all of this collaboration in terms of a National Coordination Council are only enough to coordinate the health sector. What we need to do is broaden that further and use the same word, ولاية وزارة الصحة على الصحة, to use that same slogan to expand the influence of health on education, economy, agriculture, and a range of other sectors.
Okay, I will open the question for the public. When you were in Sudan, because you worked with Sudan, right? When you went to the institute, have you managed to get this message across, or you failed to get this message across?
I learned the messages there in Sudan, alhamdulillah, and I think I'm really proud to state that I learned a lot in the Sudan. The Public Health Institute ethos is that exactly. This is where a lot of the research and a lot of the consultancy, a lot of the real think tank that was taking place.
So you were able to get your message across as diaspora. Every time the country keeps saying, like now, we need this diaspora to help and build the country. Did they listen to you? That's like I'm sorry to keep asking this question more specifically. Did they listen to your expertise?
We have been in partnership with Sudan colleagues from 2003. We have a Sudan Health Consultancy Group that has been active from the time when I was a trainee doctor. And until now, we've been working together with our colleagues who themselves trained and worked in Sudan. Some of them had some experiences overseas, but we have a very good working relationship with colleagues who are really interested on technical improvements, on learning, and in delivering the best service. I think that all of us have been limited in our capacity to influence the other sectors.
Okay, now, okay, fine, no problem. Very, very political answer. Okay, no problem. Any question from the audience before we go to the Facebook?
From what I hear from Dr. Miyad and you in the last few minutes, who is responsible for delivering a very good health service? I mean, right now, those days we hear lots of complaint about the waiting time when people go to ER, and the responsibility is to the government. I mean, that's all I'm saying. From what you say, like people should make effort, should contribute as individuals to push for the people in Sudan to get better health service. The biggest column in any budget in the developed country is the health. Like 20% from the GDP. In Sudan, I think it's less than 1% or 2%.
It's 8.4.
I mean, without the government fully engaged in delivering a better health service, the number of beds for 1,000 people it's available for people from Khartoum or from Darfur. We're going nowhere. I mean, all we say that Mayad say it's just something, it's an attempt. Like Shabab al-Hawadis and you like to go, it's individual effort. It's not going anywhere. I mean, unless people force the government to increase the budget, provide better environment for people to work, not just doctors, nurses, technicians, and health care managers. And I think always say it might be theoretically right, but in real life, it doesn't exist. And I don't see going like improving the next few years because the government doesn't want to contribute. Health service, yeah, you go private. If you can't afford it, you will get treatment. If not, you can't. As simple as that.
Any attempts to collective attempts have more impact than just one individual. So together, if together we were to say something, make a statement, and work, try and come up with solutions, between us we will come up with some workable solutions. They will only be baby steps. The point you're making about government responsibility is the government responsibility is too big with too limited resources. We've seen that here in the UK, where you are responsible for everything, but you can only deliver a small bit of it. So you have to prioritize, and I think the question is, what are the priorities? The priorities for universal coverage are to make sure that we have access to primary health care. And if we can have access to primary health care and prevention, so that people don't need to access health care, then at least that is an attempt that we know is in the right direction. We won't get there quickly enough. We haven't got there yet, but we should make a start.
Can I just add, and thank you for your question. As Mona said, we didn't say it is not the government responsibility. We said it has to be everyone's responsibility, including the government. If you want to make a difference to health, you have to empower communities, you have to look at education, you have to improve hospitals, but you have to improve health so people don't need hospital. Any system, irrespective of how rich it is, still the money will not be enough to cover the whole need. Even in this country, there is prioritization. And as Mona said, the prioritization is primary health care, it's the prevention. Okay, we are not saying, we are saying we as Sudanese, including the government, we need to adopt a different mentality. We need to look at a system-wide approach. We need to embed health across all policies, and this is the way forward. The way forward is not building more hospitals or providing more medicine or making medicine cheap. Because irrespective of how much medicine you buy, it's not going to be enough unless you reduce the need for that medicine, unless you improve the health of the population, unless you address the wider determinants of health. Through partnerships, internal and external partnerships, with communities and with the international community, and learn from within and from outside.
Okay, tamam. There's questions. Carry on. One of the questions from Dr. Hisham Al-Khidr, who is the president of the Sudanese Doctor Association in the UK and Ireland, right? نقابة الأطباء السودانيين. So he's officially the president of the. He was supposed to be here. He said, "Salam alam, I'm sorry I couldn't be here. He had family issues." His question, my comment is as follows: by looking abroad at other health systems, such as, for example, UK, USA, or other places, we cannot import their experiences or systems without importing the supporting structure. So these are good systems. UK, you take them. And one example, I gave a lecture in the Sudan National Council, where I was talking about technology transfer, how technology can move to Sudan. I remember one of the people sitting with the audience قال لي يا دكتور انت بتحلم، معلش يا سيدي العربي، انت حالم ورومانسي قاعد في برايتون جنب البيتش وبتقول لنا ترانسفير تكنولوجي. It cannot transfer. He was saying to me, you are just romantic saying about transfer technology to Sudan sitting in Brighton Beach. This is completely different environment. So please accept this criticism. But Husham saying you cannot import these systems from the US or UK without importing the supporting structure. What he means, he said mainly peace, independent judiciary, free press, then we find the health system that is sympathetic to the Sudan. So what is your answer? Oh, sorry, start by me.
Thank you very much.
Good system, but you have to bring them with the peace, with security and so on.
And I think what we need to do is to import the principles, because you can't transpose a system. You have to import the principles, the ways of working, the trust, the collaboration, the genuine interest, finding shared values, and finding win-win solutions. The solutions will be different. Each and every country will have its own set of issues. It will have its own context. It will also have a different solution that comes up that everybody is willing to work with and to try. So by importing the principle, then we should be able to make it work. I think the comment that he's making about free speech and judiciary is the same comment that I'm making about quality. It's the quality of the way we deliver our work. It's the quality of a judiciary system. It's the quality of the press. It's the quality of policy making. It's the quality of consulting and engaging with communities to get their views. Quality, I think, if everybody does their core business to the best that they possibly can and work with others to achieve shared goals, that way then we will all win, even if some of us might have to give way in some negotiation.
Okay, I'll ask you the second question, but I will give you just for a second, Dora. برضو they are watching مجلس القومي للتخصصات الطبية السوداني Medical Specialization Council. Please, since you are watching us, if you can send us a comment on what's going on here, because you also have a role to play about quality about. So if المجلس القومي للتخصصات الطبية في question يا دكتورة بس let me ask you this question. هل تعتقدي عدم وجود مراكز الرعاية الصحية الأولية؟ Let us take this to أحمد حسين. This is we can ask you. Also we have one about economy هنخليه لعبد الرحمن. في question بيقول لك في الرورال areas ليه الوضع متردي؟ Just one second. توجد الكثير نوع خوجة توجد الكثير من المشاريع التي تهتم بتقوية النظام الصحي في السودان، لكن للأسف غير موجهة التوجيه الصحيح لضعف الكوادر. هل do you agree إنه do you agree the cadre in Sudan they are not well trained, well qualified to lead these good projects في السودان? In Sudan, to what extent do you see them? Are they good enough? Are capable?
I will answer from the point of view of the research that we undertook in terms of rural health services. How can we attract and retain health professionals to work in rural areas? And many of the comments that we got back is that even if individuals are able to go there, then they need a whole sector. So they will need to have proper schools for their children, that they will need to have sort of conveniences of modern life. And that was one of the big barriers why health professionals migrated from rural areas into the urban areas and from urban areas to Khartoum and then out migration. I think it is a matter of development.
Okay,
this is a big question. This is a big question about rural development. If we can get rural development right, then we can get all services complementing each other within rural areas, then that will be sufficient for individuals to be able to work, living and working conditions in rural areas.
طيب يا دكتورة، أنا طبعا my role also to bring you what is going in the public domain. In the public domain, there is a big criticism for doctors, and I know doctors are going to eat me on this, but there's a big criticism. Doctors, they want to go to the capital city, which is Khartoum, because they can earn so much money on their private clinics. If they stay in small Madani or Gadarif or small towns, they will not earn even 10% of what they earn. They earn means in the private clinics. To what extent you think that's a reality? Or part of the problem?
Yeah. I think that there was also some work that we looked at private sector, private medical practice. And the fact of the matter is that even in rural areas or in some of the states, there are private practice opportunities, and some of the doctors were saying that actually they have more private practice opportunities because they have less competition.
Okay.
I believe that it is there are a whole set of other reasons why people are moving away from states into the capital city as a stepping stone into migration. One of the solutions we proposed was that if professional qualifications and training was more available within the states, then individuals would not need to move to for medical or training rotations in the capital state or in some of the bigger cities. So we were we proposed incentivizing rural and state locations by running strong, good training programs there for doctors not to need to access Khartoum or abroad for medical qualification. I also need to comment that the health system is not just about doctors. We've seen similarly nurses being attracted into the capital and also to travel abroad in terms of that big wave of migration that we have seen. It's affected nurses, it has affected teachers, and so it is not just simply a matter of private practice for medical practitioners.
So, Doctor, why not you all of you, the doctors who are so special, and also Husham is listening, Husham al-Khidr, the president of the Sudanese Doctors Association, you try to help the government policy, all the doctors, particularly the consultants who will willingly go and work in rural areas, they get some incentives, they get some kind of maybe land, they get lots of privileges. This government is doing it. If you work in London or area where there is a lack of doctors, you know that, it's particularly the junior staff, they pay them some incentives and so on. There is a question, I will come down, but just before we finish this one. You mentioned about the mobile election دقيقة. أشارت الدكتورة عن حلول الموبايل. You have talked about mobile solutions. محتاج إنها تشرح لنا الحتة دي. Can you explain it more? Because we are telecommunication engineer. How can we help? So you got somebody from Saudi now, telecom, he want to help. So you talked about the mobile solutions. Also, Mu'id is an IT. How can they help?
So mobile solutions are very attractive to public health because the smartphones are now getting much, much cheaper. And mobile phone network penetration is very high all across Africa. So there is an opportunity for their specific health promotion programs, for example, around maternal health, advice during pregnancy, advice around newborn children's health up to the age of 5 years, for example, to take place via the mobile phone. The fact is that mobile phone mobile health solutions have to be interoperable. They can't be just with Zain or just with Sudani. They have to work across a range of mobile phone operators. This requires the telecommunications industry in Sudan to come together and agree that there is no competition when it comes to health promotion programs, that they will be offered simultaneously and similarly with the same charging scheme to the users that one company offers to the other, so that there should be no competition around in terms of providing these health incentives. At the time we were doing our research on mobile money for the National Health Insurance Fund, that was about how can individuals, farmers, laborers who aren't employed, how can they pay their insurance premium so that they can then increase in the coverage of National Health Insurance Fund and accessibility of the health insurance benefits. At the time, one of the solutions was that you could either carry the mobile phone and have the an employee of the fund or employee of the health service collect the premiums on their own phone or on a tablet, or by enabling some sort of money transfer. Safaricom Kenya was the first mobile money initiative, and that enables virtual money to be paid. So you can pay for your taxi, you can then pay for health care, you can purchase your medicine of a pharmacy by this automatic transfer of money. We were interested in mobile money in terms of people being able to have an account. Now I know that there is something called al-Haqiba. There are lots of mobile money solutions have now started within the Sudan, but we need to make sure that our health sector colleagues are able to offer mobile money solutions that are not chargeable to the user. Because if they are charging as a telecom operator for the text messages and for a range of other, so the volume of activity, then it becomes very expensive to the user. And we know, of course, that the government cannot afford to pay for everyone universal coverage of mobile health.
So let me take this opportunity, because we have people from Zain and all this telecommunication company. They always, I can see them on TV, I will say this in English, so because some of the seniors Zain they don't speak Arabic. All the time you see them on TV talking about corporate social responsibility in their business. And I can see them, they go to some school, support this and support this. But I think this is a call for all these from telecommunication company to seriously consider their social responsibility towards the public and help the people, because this is about health. And it's not about, the government cannot not do anything. And people like even Mo Ibrahim Foundation, which is supporting, spending most of millions of pounds across the whole continent. They have to support Sudan. I think this is where I think mobile company, they really have to address this seriously. And if they want, they can get in touch with you and others. Abdurrahman, could you raise your question? Yes.
Yes, just my question is the health policies now, the health financing policies in Sudan actually favor the private sector in urban areas. So the payment mechanism is what we call it is fee for service. Basically, I pay you for, if you do an ultrasound, I'll pay you for this ultrasound. If you do a CT, I'll pay you for this CT. It doesn't take the holistic approach for the patient. And I think in changing the health finance policies from fee for service to a new one, what we call it capitation with incentives, will incentivize primary health care. And will actually, because you give them money upfront to primary healthcare service to set its service and give a maintenance throughout the year, and will actually save you money, because every pound you spend on the health on primary care, you will save £10 in secondary care.
Rahman, because we'll give you time after to talk about the finance, but maybe you can finish this one. Is the primary health care going to be free? Do you think it can be free at any point?
So,
yes or no, quickly.
So in universal health coverage, yes. Everything is free now.
So the primary health care is not going. This is Taysir. Last question. Who was yes?
What message can we send to the pharmacists in Sudan in terms of selling medication to patients without prescription, especially in terms of like malaria tablets, antibiotics, and sometimes they prescribe medication to patients without going to the doctors? What message can we send to these people? Because at the end of the day, this kind of thing can damage health to the people in Sudan.
I think that is one of the accidental issues that happen, because if an individual can't afford to go to a doctor to be able to then get a prescription and then get it from the pharmacist, I think that is just an unfortunate way of bypassing the real issues. I think that the real issues are, do we have that much malaria and infection that warrants this volume of use of anti-malarials and antibiotics? We know that we have an issue around resistance with drugs. And so all of these are compounding the problem. I think that you've hit on just one element of a whole cascade of dominoes that results ultimately in resistance. I think if we then backtrack, then the real issue is access to universal health care that is free at the point of access, and that universal health care includes essential medicines, a list of essential medicines, and we know that we should be rationing these particular medicines that you described because of the risks. It is not just a matter, it's not a trial and error for an individual patient. The error actually accumulates across the environment and will affect all of us.
Okay.
Can I just add
لا والله لا التايم انا I'll give you all question لانه انا حريص عليكم تاخذوا بريك وترجعوا هنواصل والله I'll give you all time. Sorry محمد I'll give you last question to finish لانه relating very much. ده محمد صالح محمد ياسين اظن من السعوديه تقريبا. قال لك انه it's a long question لكن قال لك how can you and the doctors or health professionals in the diaspora, this is all to you. I'm not a doctor, so I'm not part of it. The doctors, I'm just you know. How you all doctors and professionals in the health sector in diaspora work in coordination to reduce the inequality generated by the successive regimes and colonial discrimination and so on. But it's a long question. Why are you inspiring to bring a UK or a US system to Sudan while we are still at the bottom? Can you provide an appropriate system instead? When I talked last time, when I will talk whenever, all my PhD is about appropriate technology. وقالوا أي technology is not appropriate, it will not reach the user.
So
he's asking you, is this system appropriate for Sudan?
If we start by saying why when we are at the bottom, okay, so when are we going to move from the bottom?
لا دكتورة, his question, because احنا ناس بعدين يحاسبونا. If this يعني he got here. If this system you are trying to introduce to Sudan, which you think you believe is a good one here, is it appropriate means
yes,
it's easy, it can be implemented, people they have the money to, is it?
Because it doesn't depend on money only. It depends on empowering.
So you are confident as an
communities.
expert,
Yeah,
the system we talked
absolutely.
about this one, because this is very good for policy.
Because
It
it's
is appropriate for
focused-
Sudan.
It is focusing on primary care and it is focusing
Yes.
on cost effectiveness and prevention.
And you agree,
so the
Dr.
answer
Arisa?
is yes.
خلاص ده كله ده كمان جهل. Quickly.
I don't think the UK is the model to transfer.
So it's not very appropriate. It's not appropriate.
Economically
Then-
and financially.
No, we are not importing a UK system. We are learning from a UK system and adapting it to Sudan,
So,
which
okay.
is a focus on prevention and a focus on primary care.
Come on, yes, Patricia. Finish.
I'm sorry for butchering the name, but Rehab Idris Ahmed says the states in Sudan does not get their luck in improving healthcare and health services. All the services are concentrated in Khartoum.
So the same issue, yes.
Yeah, even the capacity building of the medical field workers are very limited in the states comparing with their colleagues in Khartoum. So that basically there's no access to.
And I think we will finish this point. I think all doctors, particularly the diaspora, they should now think seriously on helping the remote. I know they do. I went with the campaign before they went to Madani Kaza. So I think we're going to finish. Thank you very much, Dr. Amana. We're sorry for I think I'm going to propose we take